Okay, I need to wrap up actually, I think, shortly. One more study. There's something called the HODAR or data set, Hospital Outcomes Data Repository. There's a hospital in Wales, in Cardiff, which routinely for a number of years has got their patients to fill in an EQ5D when they're admitted and when they're discharged, and also I think about 6 months follow-up. So they've just been collecting EQ5D repeatedly on their patients. And so using this data set, this study wanted to try and investigate to what extent there was a relationship with self-reported happiness. So they had this EQ5D and some SF6D data, and they want to regress self-reported happiness on these things. And so what's driving self-reported happiness? Now, of course, there's a few challenges. The EQ5D, as we've seen, asks people about their health today. Which statement best describes how you feel today? SF6D asks about your physical functioning on a typical day, so some sort of average over time. And some other items in the SF6D explicitly refer to the past 4 weeks. So you have to bear in mind they're asking different question about a different time period. The happiness question, have you been happy, refers to the past 4 weeks. And so you have to bear that in mind. And then in response to the happiness question, the respondents choose the answers none of the time, a little of the time, some, most, or all. And so what they, this is the results for the EQ5D3L. And so they've taken people's self-reported happiness over the past 4 weeks, and they're trying to explain it using the information they've provided on EQ5D. Which mobility level are you at, which self-care level, etc. And so these things here, these odds ratios, really should all be under 1, because the idea is the poorer health is reducing your self-reported happiness. And more than that, as you move to a poorer level of mobility or a poorer level of self-care, usual activities, the odds ratio should be falling. And by and large it is. I mean, okay, this value is above just over 1, but the value is tending to fall as we go between these pairs of levels. If we do the same thing for the SF6D, we've got physical functioning just not performing well at all. All these values should be less than 1. They should be reducing your self-reported happiness. More than that, the poorer levels of physical functioning are getting higher scores, not lower scores. So there's something slightly strange going on. According to the SF6D, the poorer your physical functioning, the more likely you are to be happier. Other ones that are behaving a bit better, if we look at, for example, pain, they're below 1. And they're not quite a right pattern, but they're tending to decline. And so it's behaving a bit better. Social functioning is behaving as we predict. Mental health is behaving as we predict. And vitality is behaving as we predict. What would we conclude? There does seem to be a bit of a relationship between these health measures and happiness, but not nearly as clear-cut as we might anticipate. Although you could say the EQ5D is kind of behaving, but SF6D not really. Interestingly, the authors kind of say both aren't behaving. I say interestingly because the author here, Brazier, developed the 6D. But anyway, right. Yeah. This is another study which does suggest that the EQ5D3L, which has this strong emphasis on mobility, is maybe a little bit at odds with other information we've got that suggests mental health is a bit more important. And just to close almost, it's quite interesting that the new valuation for the EQ5D5L from England does find mental health to be rather more important than it was in the past. But anyway, let's try and draw some conclusions. Right, money first of all. Clearly there's some advantages in using money. Money is a way of measuring strength of preference. It's a way of valuing attributes beyond health. It means that you've already measured your benefit in the same terms as you measured costs. So that helps. Everything's money, money, money. We don't have to worry about how much should we be willing to pay for a health benefit. It also means you can compare what's going on in different sectors beyond health. But clearly challenges. It's still stated preference, it's not revealed preference, so there's an issue about validity. Different methods give different answers, so there's a question about what is the best method to use in which circumstances. There's been, I'm just giving you a very selective run through the literature, but there's been a certain amount of interest in recent years in well-being valuation. It's not been restricted to the health sector. People in general have been talking about well-being as a means to judge between policies, for example. The well-being approach, or the life satisfaction approach, I think shares some of the advantages that willingness to pay does. It maybe has potential wide application. But like willingness to pay, I think there's no sign that well-being or life satisfaction is going to supplant the QALY in the near future. The QALY, despite its problems and challenges, has really quite a substantial body of research behind it. The well-being research, life satisfaction research, by contrast, is a bit more in its infancy, and we know a bit less. And so, in summary, for these alternatives to the QALY, I don't see things changing much in the near future, but they've each got some merit. I think it's too early to write them off. Having said that, willingness to pay for health benefits has been around for several decades, and so if it was really going to break through, you think it might have happened by now. Okay, I'll stop there. Thanks very much, and we resume on Friday.